Good morning, everyone. Happy Friday. Welcome to today's session of COVID Community of Practice, Changing the Way We Work. I'm Eleanor College. I'm a family physician. I work in East Toronto. I'm also the CPD Program Director at the University of Toronto, the Department of Family and Community Medicine. I'm really happy that we can continue to collaborate with the OCFP to bring you these sessions, and excited to moderate today's session on infectious disease and OBSP updates. I'm going to turn things over now to our OCF President, Dr. Jobin Verghese, to open our session.
Thank you very much. As we go to the next slide, I'd like to do the land acknowledgement. I'd like to thank Dr. Eleanor College and the entire team for this. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognizes that many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respects that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. Dr. College, I'll pass it back to you.
Thanks, Jobin. So as I was reflecting on what to speak about today, I was thinking about how often I commute downtown, and if I do, I always ride my bike to avoid the Toronto gridlock. And for the past couple of years, my route has taken me past a place called Allen Garden, which is the red spot in the middle of this map. And I'd noticed there were these three large teepees or tents that have been up there for a couple of years now, and often, in my mind at least, the beautiful smell of burning wood. And I thought in my journey of learning, would figure out a little bit more about what was happening there. So I dug into this a bit deeper and found out that actually the Allen Gardens is one of three sites that's been set aside in Toronto for sacred fires. And these sites were set aside in 2022, or designated by the City of Toronto as part of their Reconciliation Action Plan, recognizing that that sacred fires are important, a very important part of Indigenous culture in terms of healing, wellness, and gathering. They were introduced to help reduce the barriers that Indigenous people were experiencing in terms of holding sacred fires. I should point out that actually you can have sacred fires at other sites. These just happen to be three of the designated ones within Toronto. And I was just thinking and reflecting on how it's nice to see some physical signs of us taking steps forward, even if there are many other steps that we need to take forward. It's nice to see some evidence that things are happening. And I would encourage other people to look around their community and see what's happening in terms of placemaking and placekeeping, which is what sacred fires are part of this tradition. So with that, can I turn to the next slide, please? So just a reminder, this is part of a series. It's put together by a big committee that are very helpful in terms of getting everything running. Next slide, please. And at this point, I'd like to introduce our speakers. I'll turn things over first to Dr. Alison McGeer.
Morning, everyone. Alison McGeer, infectious diseases at Sinai Health. And you see my disclosures on the top of this. As you know, I do a lot of work with a variety of companies that make both vaccines and antivirals. Thanks.
Thanks, Alison. I'll turn things over now to Dr. Dan Wachowski.
Hi, morning, everybody. Daniel Warshawski, one of the Associate Chief Medical Officers of Health in the province. Still nothing to disclose.
Thanks, Dan. Turn things over now to Dr. Jonathan Eisenberg.
Hi, Jonathan Eisenberg, family physician at Lamb Community Health Centre, provincial primary care lead of cancer screening at Ontario Health. I have nothing to disclose.
And now to Dr. Samantha Feinberg.
Hi, Samantha Feinberg. I'm the clinical lead for the OBSP at Ontario Health, and I'm a radiologist at Lake Ridge. And I have no conflicts of interest.
Thanks, Dr. Feinberg. And now over to you, Jobin.
Thanks so much. Hi, everybody. Jobin Verghese, family physician and president of the Ontario College of Family Physician. Also two administrative hats as the interim assistant dean of primary care education and TMU School of Medicine, and Associate Vice President of Academics at Osler. Thanks.
Thanks. And lastly, for myself, I receive an honorary from the OCFP and do some work for the Foundation for Medical Practice Education at McMaster, otherwise no declarations. Next slide, please. So just a reminder how to participate. Please put your questions in the Q&A. And if you see a question that's already there that you would like answered, then upvote it rather than writing it again, as I will prioritize those that are upvoted. And then, of course, use the chat to share your resources, say hello to others, and generally just communicate with everybody else. Next slide, please. So in terms of today's format, we're going to start from hearing from Allison and Dan, and then we'll break for questions and then turn things over for the second half to Jonathan and Samantha. Okay, thanks very much. Next slide. Let's turn things over to Dr. McGeer.
Thanks very much. Okay, so there's just a little bit of new stuff about respiratory viral illnesses. So I'm going to start with overall. This was when I was looking for vaccine efficacy estimates from Australia, which ought to be out so far, but are not yet. But what they did have was, to me, a really nice illustration of thinking about relative burden of where we are with SARS-CoV-2, influenza, RSV, and other respiratory pathogens. So here you see the distribution of people admitted to the ICU with severe respiratory illness by what was causing the illness. I think Australia is a little bit behind us in terms of SARS-CoV-2 because they did so well for so long early in the pandemic. But really still, COVID significantly worse than influenza still. Influenza about twice what RSV is, and then everything else together about the same as influenza. So it's just, if you're talking to people about burden, which is critically important to getting people vaccinated, that's the order we should be thinking about them in for this winter coming up. Next slide. Okay. Still a lot of discussion about whether getting a booster this fall is worth it and how different it is from previous vaccines. So this is one way of looking at it. This is a schematic of the spike protein of SARS-CoV-2. And on the left-hand side of this, you can see XBB.1.5 compared to JN1. 48 amino acid mutations in the spike protein different between the two. So really very different structure of the spike protein and antigenic response. In comparison, on the right side, you see the difference between JN1 and KP2, and the two amino acid changes at the bottom that are not marked are the difference between JN1 and KP3. So nothing in major active sites, and these are really very similar. So either JN1 or KP2, KP3 vaccines are very different from XBB.1.5, which is the first piece of telling you that you should get vaccinated this fall. Next slide. And this is another way of looking at it. This is what's called antigenic cartography. Every little square on this graph represents a twofold difference in antibody level between your response to different viruses. So here on the bottom, you see D641G, which is the original strain of SARS-CoV-2. And then we went up to Omicron through BA1, 2, and 5. And then we veered off to the left into XBB.1.5. And while that was happening, SARS-CoV-2 was evolving off to the right into JN1, KP2, and KP3. But what you see here again is that really tight linkage between KP2, KP3, and JN1 that tells you that any one of those as an antigenic target is going to cover current viruses. Next slide. And there's nothing much new in viruses. The left-hand side of this is Ontario variant, and you can see that a big blue square in the middle is what's our most common virus in Ontario now, which is KP.3.1.1. Again, a KP3 strain, so closely related to the KP2 that's an mRNA vaccine. And the right-hand side is the variant that people have been talking about in Northern Europe, starting to appear in the US. We haven't seen much of it, which is XEC. X, if you remember, means that it's a recombinant, and this is a strain that is half KP3.3 and half KS.1.1, which is a direct descendant of JN1. So XEC this winter will be fine, and so far there's nothing else out there, fingers and toes crossed, that's looking like anything particularly different. So this year's vaccine is significantly different from last year's, and is going to work better against the strains that are out there now. And remembering that even though COVID feels like it's gone, right? We've had more than 1,200 deaths in Canada from COVID in the last 3 months. So it's for frail adults, for adults with immunocompromised, for older adults, still not a trivial infection. Next slide. Okay, so 3 things, and this is my interpretation of NACI's COVID recommendations this fall. Fundamentally, what NACI is saying is we need to stop worrying about how long ago you had a shot and how long ago you had COVID. So the NACI has emphasized that the minimum time from a previous vaccine to this fall's vaccine dose is 3 months. The reason for that is to get us out of this balancing act of exactly how long it is. And when I go over the exactly 6 months or 168 days, can I get my shot? Because that's interfering with just getting vaccines into people. So when it's 3 months, there's very few people who've had a vaccine in the last 3 months, and it just makes things easier and more efficient for vaccination clinics. And of course, the issue with COVID now is not a lot of COVID tests around, not a lot of reason for many people to get tested for COVID when they have it, if they can just stay home or put a mask on for a few days. So because we're not testing, it's no longer that helpful to say, you know, if you've had COVID in the last 6 months, it's okay, don't get your shot. We will deliver more effective vaccine programs if we just move COVID into the flu category of you get your COVID shot every year, and that's now. And so this is movement on that. Doesn't mean if somebody says to you, well, I just had COVID last week, do I need my shot? The answer is no, you can wait. But it gets us away theoretically from the issue of somebody who had it 4 months ago and they're going to wait 2 months, but then 2 months is coming up to the holidays and things get really busy and they forget to get their vaccine, which is not what we want. Okay. The third thing that NACI said this fall is that COVID vaccines can be given at the same time or any time before or after any other vaccine. And that's just a reflection of enough studies of co-administration now that you know that it's okay to give vaccines together. And while you're thinking about giving vaccines together, next slide. Okay, we're coming back to vaccines together in a moment. We do have just recently an estimate of influenza vaccine effectiveness against hospitalization from South America. You can see their estimates here, 39% in kids, 58% in younger adults with comorbidities, 28% in older adults. You know, look at that and say it's low, and you're right, it's an H3N2 season. The other thing that I don't completely understand about these data, this is a South American a system that is funded by the CDC. They first reported data in the season immediately before the pandemic. And in that season, their estimates of effectiveness were about 10% less than ours in North America or the Australian estimates for that year. I don't understand why. But I'm looking at these data and saying, I really want to see what the Australian data look like, because it may be this is a reflection of the fact that for some reason, the way that system estimates data makes it look less effective than either. Either way, it's statistically significant, and we're back to with flu vaccine, right? It's not great. What it is much better than nothing. Next slide. Okay, so 3 things to think about when you're thinking about COVID and flu vaccines together, because I think everybody's reaction to it, mine initially too, was, do I really want to get 2 shots at the same time? And so the first thing about this is that, you know, every 2-month-old in the province gets 3 needles. And it's just a little bit odd sometimes to be thinking about the fact that, you know, if I had grandchildren, my grandchildren were getting their shots, I wouldn't think twice about them going to the doctor and getting 3 needles. So why is it that I'm thinking I don't want 2 needles at the same time myself? Bit weird, right? So a piece of this is just getting used to doing this. The second reason for co-administration is that last year, again, any number of other studies, most important reason why older adults miss fall vaccines is because they just didn't get around to it, not that they didn't mean to do it. And if you get your shots at the same time, you only have to get around to it once, not twice, which just means more reliable distribution of vaccines. So that's a good reason to think about it. And the third thing is that we got lots of experience with concomitant vaccines now. Next slide. So this is data presented at the ACIP meeting this year in June about older American adults who received concomitant vaccines last year. And I just want to point out to you this little box down here, which says that nearly 1 million American adults over the age of 65 got flu, COVID, and RSV vaccines at the same time in offices last year. And, you know, it's fine, right? Nothing terrible happened. The V-Safe in the United States did not explode with people having serious adverse reactions. Really, yes, COVID vaccines are reactogenic. Yes, some people feel punked the day after they get their COVID vaccine, but concomitant vaccines really are not a problem. Next slide. Okay, and then lastly, just to make ourselves feel better about vaccines, this is a poster recently presented at CHEST from GSK on their RSV vaccine. This is the first time we've seen data of 3 seasons. It's not quite 3 years because the 2022 season was offset, so it's kind of 2.5 years of data. It's a bit weird. Still, it's 3 seasons. And if you look at, right, remember that these big randomized controlled trials are not big enough to test efficacy against hospitalization, but they can test efficacy against medically attended lower respiratory tract disease due to RSV, and their estimate of efficacy summed over 3 seasons is 77%. Does look, when you look at the individual seasons, as if the efficacy is dropping a little bit over time, but none of them are statistically significantly different. So a piece of good news about the RSV vaccine is it does look like it lasts longer than any of us were anticipating when it started, and that's kind of nice. And with that, I think that's the last slide. I will turn it over to Dan.
Great. Thanks, Allison. Hi, everybody. I'm just going to give some quick updates in terms of timelines and some of the program specifics, so we can jump to the next slide. So first up for COVID and flu, when are you getting your stuff? When can you start administration? All those pieces. So we got the initial supply of flu and COVID vaccines just in late September. As always, those initial doses go out to those high-risk settings first, so hospitals and long-term care homes for those residents, staff, caregivers, et cetera, in those settings. And that's really the initial rollout. And so that's going pretty well at this point already. As soon as those sites are hit with their vaccine supply, it then opens up to the rest of the priority populations. So basically, as soon as that vaccine becomes available, it starts going out to pharmacy and primary care providers to be able to administer the rest of it. This month, October, remains the high-risk month for everybody. So right now is getting those high-risk priority populations for flu and COVID. There is the ability in that to co-administer, as Allison mentioned. So things like kids under 5 who are high risk for flu, they can still get their COVID vaccine at the same time now, even though they're not technically high risk for COVID. Anything we can do to increase the uptake and make sure everybody's able to get things as easily as possible. October 28th is the official date for open up to the general population for everybody to come in and get their COVID and flu shots. Sometimes we're lucky, supply comes in faster and we can do it before that. And if that's the case, then that'll be made known to everybody. But at this point in time, it's October 28th when we open up to the rest of the general population. Next slide, please. Just quickly run through again what products we have for flu and COVID. So for flu, we have the usual swath of different quadrivalent, high dose, and adjuvanted products. Again, so the high dose and adjuvanted products initially go out to the hospital and long-term care homes to get to those high-risk settings, as well as then retirement homes. High-risk individuals should be getting one of those enhanced products, either the high dose or the adjuvanted. And then we have the various quadrivalents. We don't have things like flu mist. We haven't had it in many, many years, although it may be available on the private market at this point in time as well. But it's not something that's in the publicly funded program anymore. So these are the products you have. Again, either of the enhanced products for older adults or other high risk if possible. But if not available, they can still get a quadrivalent and it's still great. Next slide, please. For COVID, as Alice mentioned, though technically the recommendation is that 6-month interval, come get it at 3 months for if anybody's high risk. We just want people to come and get it as soon as they can, so they're protected for the season. We only have the 2 products so far this year, Moderna and Pfizer. We don't have Novavax available at this point in time. Probably most people are aware of what the federal government put out about the limitations in contracting to get Novavax. And so while we're still working to see if any supply will be available, there's certainly not any confirmation that it will be or will be anytime soon. So if you do have patients waiting for Novavax, I would strongly urge them to get an mRNA product at this time, just because we don't know if Novavax will be coming at all. And again, timelines for this one were pretty similar to flu. We got to hospitals and long-term care homes already. Now is where it's getting out to pharmacy and primary care through the beginning to mid of October. Next slide, please. I just wanted to say that the pharmacy locator tool's been updated, so that's great. It tells people what pharmacies have available. The last update was a little more, not quite 2 weeks ago. It's updated as frequently as possible, but basically it keeps things available so that public health units and others can identify what pharmacies have COVID vaccines. So that's great. Next slide. Okay, so in terms of our RSV programs, everything's on a totally different timeline than flu and COVID. So for the adult RSV program, which again is quite narrow still, it's not a population level program, that started actually in mid-August, getting out to long-term care homes and retirement homes. So most long-term care homes at this point are able to do their own administration, which is wonderful. Retirement homes, it's a lot more hit and miss. So public health units supporting retirement homes and that administration over August into September. And the latest we have, unfortunately, we can't track every dose administered in these settings, is that the majority of long-term care homes and retirement homes have already had access to RSV vaccines, and that the residents who want it have gotten it. So hopefully we got better uptake than last year, but we get that data unfortunately quite late. When September hit, that's when we had supply in public health units to order for those other high-risk populations. That includes pregnant individuals who were wanted to get it for their infant before the start of the season. That also includes, dialysis patients. It includes First Nations and Inuit and Métis populations, people who are homeless and underhoused. Those are all the other high-risk populations for adult RSV vaccine. And again, that availability can be ordered through primary care if you have patients meeting those criteria through your local public health unit. In mid-October, so like last week, is when we just got the 100 milligram doses for Beyfortus in supply. That's gone to public health units and hospitals to have available. And probably this week, people will start be able to order for your offices to get those 100 milligram doses for infants. Again, it's just the timing of exactly when to get it is really health unit dependent, but talk to your local public health unit, put your orders in, and as soon as it's available, they'll get it to you. We're hoping to get the 50 milligram doses, so that's the one for the newborns born in hospital, ideally next week, and so that can start next week getting to all of those high-risk newborns. So that's wonderful if we can do that. Next slide. This is just for everybody. I won't go through it now, but a reminder of who those high-risk groups are this year who are funded for the RSV program in Ontario. There is RSV vaccine available for older adults on the private market. You just need a prescription from your primary care provider to access it, and then it can be received in the pharmacy setting. But again, that is out of pocket and pay if you have to do that one. Next slide. And again, as the quick reminder, we have the 2 products for infants available. The Beyfortus is strongly recommended. It's every infant born in 2024 up to 1 year of age, everyone born during the season, and then those high-risk kids, same eligibility essentially as the Synergist program has been previously, with severe cardiac or pulmonary issues, who are eligible up to age of 2. Dosing is in here. I think it's pretty easy to administer. The Abrysvo vaccine, as I mentioned, has been available since September for pregnant individuals. It's not the preferred product. We really prefer Beyfortus because it's a lot better. But if that's what someone's interested in getting, then it's available as well. Next one. This one I put in just because I know we got a ton of questions about it already. Again, just for people's reference, there's an expiration date on all the products you get. If it's maintained in fridge temperatures, then it can stay in fridge temperatures as long as the expiration date. If there's excursion, if you take it out to use it, if it gets above that 8 degrees and you're having it at room temperature, then you really have to use it. You can't put it back in the fridge, unfortunately, and get it back down there. You have to use it within those 8 hours or even 4 hours if it's quite hot in your offices. Okay, I think that's everything I had.
Excellent. Thanks very much, Dan and Allison. So maybe we'll turn to a few questions at this point. I'll probably get both of you on the screen so that I can direct them to whoever is most appropriate. So a quick question, well, not a quick question, but a question I think probably first for you, Dan. Now that Paxlovid is private pay for those under age 65, high risk, can it now be prescribed in advance of travel or to have on hand? Because there's often a more than 24-hour delay in getting Paxlovid at shoppers, and they don't keep it in stock due to price. Just wondering if this can be clarified.
Yeah, great question. So there is a slight Paxlovid shortage right now. That's expected to go on for probably another 3-ish weeks. So even getting it in that 24 hours is potentially gonna be a little bit tougher right now for both the private or publicly funded. We're not procuring supply in Ontario, it's just whatever's there. So you can still prescribe an order and hopefully someone can get it quickly. The publicly funded program is still the same in that you have to have a positive test confirmed in order to meet those LU code requirements and be considered eligible. For private, there's still the recommendation or requirement for pharmacists to confirm positivity for someone to receive it, but that can be verbally confirmed. They don't need to actually physically see a positive test result, something like that. So you just would tell them that you are positive.
Thanks, Dan. And while we're on the topic of Paxlovid, a question regarding the effectiveness of Paxlovid in healthy seniors, either for you or Allison.
You want to go first, Allison?
Okay, well, think of that, Dan. I think the answer is we don't know. Paxlovid has consistently in observational studies and trials resulted in decreased mortality in at-risk people, most biggest effect seen in immunocompromised folk, but also in older adults. The challenge is that even for most healthy older adults at the moment, your risk of complicated disease is pretty low. And what there isn't is evidence that Paxlovid is more likely to make you recover faster, which is the other thing we'd like. And there's a sense that the effect of Paxlovid is probably lower in people who've had lots of previous infections and lots of vaccine doses. So I think everybody's shifting to, okay, we want somebody if we're prescribing Paxlovid, we want it to be somebody who is older and frailer than we would have prescribed Paxlovid for 2 years ago or even a year ago. So, a perfectly healthy 65-year-old or 70-year-old who's, up to date with their vaccines, probably not going to get enough benefit from Paxlovid to want it. However, somebody who is pre-frail, multiple comorbidities, and anybody who's immunocompromised, yep, definitely on, okay? Nowadays, of course, there's also the issue of can you afford to pay for it? Because it's also really expensive if you have to pay for it yourself. I think we're still using federal supply, okay? So it's not like real money we're spending just at the moment for Paxlovid in the public supply for people who are eligible for it. It's money that I think has been spent already, but still, it's this is an expensive drug, and you do want to be careful about who you're prescribing it for.
Yeah, I agree with what you said, Allison, and I think the updated OH criteria reflect that. It's really focused on immunocompromised or multi-comorbids. Just to be clear, though, we aren't actually getting federal supply anymore.
Okay.
It's just on the market, and then we are reimbursing through ODB with the contracts there. So it would be nice to still get federal supply. We are getting federal supply for COVID vaccines this year, but not for Paxlovid.
Thanks. Well, thank you both for clarifying where things are at with respect to prescribing and Paxlovid. Thinking about vaccines, actually, there were a couple of questions that came up regarding the COVID vaccine, some of which I know you answered, Allison, I think it typed in, but quick question, which, is there a preference Moderna versus Pfizer? I just wanted to put that one out there.
No.
Nope, excellent. And are you suggesting should everybody get a COVID booster regardless of age or risk factors?
So NACI and most other NITAGs are distinguishing now flu vaccine and COVID vaccine. So there's an absolute recommendation, a should, for people who are over 65, who are immunocompromised, who have multiple comorbidities. For everybody else, it's a may. And so COVID vaccine, think of COVID vaccine as moving into flu vaccine territory, which is that older adults, yes, all of us should be getting our COVID vaccine. And remember, we're back to COVID vaccine's about as effective as flu vaccine, not perfect, but good. And COVID, there's a higher burden of COVID coming than flu coming. So if you're somebody who routinely gets your flu vaccine, you should be routinely getting your COVID vaccine as well to protect yourself if you're older or at risk. For younger adults, same thing, right? COVID can make you miserably ill. If you don't want to be miserably ill from SARS-CoV-2, getting your vaccine is a good idea. If you are around people that you can transmit to, who are vulnerable, getting your vaccine reduces the chances that you can do that. So it's a sensible choice for younger people, but it's no longer in the category of you definitely should get your COVID booster.
Thanks, Allison. Can either you or Dan clarify just in terms of the pediatric population, would they just fall into the younger, as you were mentioning, younger people?
Sorry, one more time, Eleanor.
Yeah, just wondering for pediatric specifically, what are the recommendations around the COVID vaccine?
Same as, so here there's a, right, we prioritize kids under 5 for flu vaccine, not recommend. So for COVID vaccine, under 5s are like everybody else who's not at high risk, which is a may get vaccine, but not a should get vaccine.
Excellent, thanks for clarifying that. Another question just around vaccines. In terms of administration, I think you covered this, Allison, can the RSV vaccine be administered with other vaccines?
Yes.
Excellent. And then also just thinking about the RSV vaccine, is there any preference if patients are private paying? Would you recommend a Arexvy versus a Brisvo? Is there any difference or recommendations there?
Best data we have at the moment, to my mind, is the observational data in the United States on prevention of hospitalization, which is really why we're, using RSV vaccine. And in those studies, there's absolutely no difference between the two of them. They look identical. I don't think there's anything to pick.
Excellent. Just in terms of logistics, Dan, and this might come more towards you, in terms of the COVID vaccine, will it be administered at all by public health units? And then there's just a comment here, as a family physician who does large flu shot clinics that are well attended, we'd love to give COVID vaccines at the same time, but the admin burden, Covaxin precludes that. Hopefully the system can change to make it easier for us to do this work for our patients. Just wondering where things are at in terms of those logistics.
Yeah, it's a great question. For COVID, COVAX is still a requirement. It's actually a legislative requirement. So to change it and get out of it is actually quite a big deal. Things were put in place in the emergency part of the pandemic, and so it's very hard to get out of that. So until we have a good alternative solution, it's still required to document in COVAX. At this point, the public health units are still giving COVID and flu clinics. It's really targeted at high risk and vulnerable groups who don't have access to healthcare otherwise. So unattached patients, homeless and underhoused, new immigrant communities. That's really where they focus their efforts, not on kind of the general public who can walk into a pharmacy. At this point, pharmacies doing like the vast majority of COVID vaccines, roughly 80 to 85% are administered through pharmacy, another 10-ish% through public health, and we're at like 5-ish%, maybe 5 to 8% through primary care. Whereas for flu, we have like that 50-50 split between pharmacy and primary care. So we really hope to get past that COVID burden in the near COVAX burden in the near future to get primary care really engaged.
I think, and this is a personal plea for me, about if any of us get a chance at any time to be part of the solution to recording and administering vaccines, that there's nothing particularly easy about it. I'm really conscious of the admin burden in primary care, but we have to have a solution in Ontario that allows us to track which vaccines we get. One of the things I really worry about now is we're giving out pneumococcal vaccine and RSV vaccine. And, 10 years from now, when I go into a long-term care home, despite my best efforts, nobody's going to know when I've had which vaccines. And I think that applies to a huge burden of adults. So vaccines for adults are really good. They're going to save us in, money. They're going to save us in physician visits and workload and vaccine and hospitalizations. But if we don't have a method of tracking them, we're going to get into real trouble. And it's fine to have it at the level of providers, but my family physician retired, right? And 10 years from now, my new family physician is going to be retired, and thinking that we're going to track through things is without having a provincial system that's like, hospital records, is, I think, just not realistic. So despite the fact that I know this is a pain in the neck to work on for everybody, this is a plea to everybody to just say yes when somebody asks you to think about it and work on it and try to contribute to building the system. Sorry, I'll get off my soapbox now.
Thanks, Allison. Well, just thinking about it, it is a challenging from both sides, and there's a few comments about, within the EMRs, for example, we obviously could easily share information with public health units. But yeah, it's this back and forth of how to make sure that we're tracking well, because sometimes we end up, as somebody pointed out, giving vaccines again because we don't know, there's been no record. Anyway, I'm actually going to have to stop there because we'll come back to you perhaps with some more questions at the end, but I want to turn things over to our next speakers, Dr. Eisenberg and Dr. Feinberg.
Thanks, Dr. College. Hello, everyone. Dr. Samantha Feinberg and I are excited to be speaking today about the Ontario Breast Screening Program and share a quick overview on the expansion to those aged 40 to 49. We've already given our introduction, so I'm just going to invite Sam, without further ado, to start us off with this overview. Thank you.
Thanks, Jonathan. So I'm just going to give a bit of background about the OBSP and the screening program. So the OBSP is a provincial-wide organized breast cancer screening program. It was launched in 1990, and its aims is to reduce breast cancer deaths through regular screening. And we screen two different groups of people in Ontario for breast cancer, those at average risk and those at high risk. And as of October 8th, people ages 40 to 49 are now included in the screening population. Okay, so yeah, next slide. Okay, so we did get a bunch of questions about some of the policy around screening. So in terms of the average risk OBSP, as of October 8, 2024, we have kind of two subpopulations within the average risk screening program. But those who are average risk, ages now 40 to 74, the recommended screening modality is mammography, and the recommended screening interval is every 2 years for most of the population. And then within the average risk program, we do have like a subpopulation that comes back every year instead of every 2 years. So they have a more intense screening interval. The recommended screening modality is mammography. And so those who are getting called back every year are people who've had high risk benign pathology on previous biopsies or due to family history. We also call back people every year if they have high breast density, so they have BI-RADS-D on their mammograms, or like the radiologist has seen like just the appearance of the mammogram. They do have an option to call someone back in 1 year versus every 2 years. So that might be like the appearance of the mammogram, or that they were called back for assessment, and then the radiologist will say, okay, instead of 2 years, come back at that 1 year. So they'll have that temporary 1 year recall. Okay, next slide. Okay, so I just want to give a bit of background for the evidence for why the program has expanded. There's been a slight increase in breast cancer incidence in females ages 40 to 49 in Ontario. We also looked at we had some OHIP data as to who's been screened outside the OBSP in 40 to 49. and females ages 40 to 49 who did receive a screening mammogram in Ontario outside the screening program were more likely to be diagnosed at an earlier stage than those who hadn't. And there's also inequities in the mammography screening population for females ages 40 to 49. Those with no mammogram had a higher percentage of people. They're more likely to be from materially deprived communities and lower income neighborhoods than the more ethnically concentrated communities. Okay, yeah, next slide. Okay, so this is some of the data from the US task force. The Canadian task force modeling data it has not been finalized. So when we have that information available, we will also share that information. So this is some of the benefits and harms of screening. It's based on modeling, looking at screening strategies for people undergoing screening with digital mammography for a cohort of 1,000 40-year-old female persons compared with no screening. And they compared starting at 40 versus starting at 50. And if you start at 40, there's a slight improvement in mortality reduction from 24% to 28%. So 4% more reduction in mortality if you start screening at 40 versus 50. Slight increase in deaths averted. Like 1 to 2 more deaths prevented over a lifetime if you start screening at 40 versus 50. There is a significant increase in false positives. So if you start at 50, about a little over 1,000 people will have a false positive. So that's over their lifetime of screening. People will probably get called back once for a false positive, which means like getting extra testing. And if you start at 40, that increases to like over 1,500. So that means if you start at 40 to 74, people will get called back once or twice for a false positive on their mammogram. And there's a slight increase in overdiagnosed cases if you start at 40 versus 50. So when you look at like screening strategies starting at 40 versus 50, there might be a small reduction in there's going to be a small reduction in breast cancer deaths and mortality overall. There is going to be more false positives when you start screening at 40, and there may be a chance of a small increase in overdiagnosis. So finding a cancer that might not have harmed or caused more mortality. Okay, so next.
Thanks, Sam.
Yeah. Okay.
So let's start at the bolded title sentence at the top of the slide where it says Ontario Breast Screening Program 40 to 49, breast cancer screening conversations. And just pause here for a moment because the expansion of the Ontario Breast Screening Program to those age 40 to 49 really goes hand in hand with the concept of informed decision-making in the form of breast screening conversations. And before going further down the slide, I just wish to make clear an important distinction about the Ontario Breast Screening Program recommendations between the different age groups. So among those people aged 50 to 74, the OBSB recommends they get breast cancer screening. Whereas for those aged 40 to 49, it's a bit different. The OBSB encourages these people to make a personal decision about breast cancer screening after speaking with a healthcare provider. So as such, a breast screening conversation needs to happen to help people understand their personal risk for breast cancer, the potential benefits and harms for breast cancer screening, and then with that information, discuss and figure out what matters most to them in taking care of their health. And these conversations are important because generally people ages 40 to 49 have a lower chance of getting breast cancer compared to those ages 50 to 74. And that balance between potential benefits and potential harms of regular breast screening may be different for people in this younger age cohort. So let's return back to the body of the slide, which illustrates how people can access breast screening with the OBSB. And with a primary care shortage, not every Ontarian has the same access to a healthcare provider. So the breast screening program has built 3 entry points, which you see illustrated, that allow those ages 40 to 49 to have a breast screening conversation. So that can be either with primary care, which is seen in the middle, calling 811 to speak to a trained navigator, or on the right-hand side, accessing a prevention specialist. And in either of these 3 avenues, that's where the breast screening conversations can happen. So again, that's discussing individual breast cancer risk, potential benefits and harms of screening, and exploring personal values and preferences. And then moving down below, if a person decides to screen, they can then get referred by their healthcare provider or self-refer for a mammogram. And finally, once that mammogram is completed, in terms of the follow-up of results, all people ages 40 to 49 will receive normal result letters if they have a normal screening results. And they'll also be provided with information about recall interval and breast density. And for patients who are attached and have a primary healthcare provider, the healthcare practitioner will get a copy of the mammogram screening report with both abnormal or abnormal results. For those who are unattached or don't have a primary care provider, the OBSP screening site will then connect that individual to a primary care provider designate who receives that screening report, and that designate will follow the patient through to diagnosis if the result is abnormal. Next slide, please. So again, for people ages 40 to 49, screening is a personal decision, and our goal is to help people make a decision with the information we are giving them instead of leading a person towards a decision to screen or not screen. And family doctors and nurse practitioners, we just need to be ready and willing to engage in these discussions with people ages 40 to 49 who show an interest or have questions about breast cancer screening. And this provider resource is a guide that has been made to support conversations between healthcare providers and those ages 40 to 49. And this in this guide, you can see there's different subsections, setting the stage for decision making, a discussion around the risk of breast cancer in people in their 40s versus 50s and older. There's mention of the breast cancer risk assessment tool, which people can fill out online, and after filling out the questionnaire, people can understand the risk of breast cancer compared to other people in the same age group. There's information around race, ethnicity, and xenography status, a section on discussing values, preferences, and again, the potential benefits and harms of breast cancer. There's also a section on, given that this is a younger age cohort, there's a section on counseling people who are pregnant and lactating. And then finally, a brief overview of next steps if someone chooses to screen or not screen. Next slide, please. So this summarizes some of the resources that are available to support people ages, to get screened ages 40 to 49. So the primary care resources include the provider conversation guide that I've already mentioned. There's also frequently asked questions document, which is a set of FAQs for primary care providers to reference. Our Ontario Health Cancer Care Ontario websites have been updated to reflect the expansion. Public resources include a public fact sheet, the My Cancer IQ online web tool that can assess for individualized risk of breast cancer. There's website information that can guide people where they can get screening at OBSP locations, as well as informing people of the wait times for mammography, an appointment booking line, and then again, updates to our website. And back to you, Sam. I'll ask you to speak about next steps. Thank you.
Okay, thank you. Yeah, so we are going to, the OBSP will be working on other elements of expansion, including correspondence. So currently, participants who have a normal result will get normal result letter, which will include their recall interval and breast density information. But other elements of expansion, including like those reminder letters, the recall correspondence, and like promotional materials and culturally tailored materials are going to be part of future steps of the expansion. And there's also going to be more work to build capacity for screening and breast assessments. And I know we have a Q&A, but you can take down this email. So if you think of any other questions after this talk, we'll be happy to answer them.
Thanks very much. I think that was, I think that was the last slide. Thanks for taking those down, Olivia. So thanks for telling us about the expansion of the program. There's a few questions that I was hoping to direct at you both. So the first one was, why is automated breast ultrasound not covered by OHIP?
There was a bunch of questions about supplemental screening and recommendations for high breast density. So currently in the screening program, if someone has BI-RADS D, they are called back every year instead of every 2 years. And there was actually a Canadian-wide, this is sort of unique to the Canadian screening programs, that 1 year versus 2 years. And actually it was looked at, like in Canada, that more intense screening every year for people who have that very high breast density. It did show an improved cancer detection rate and reduce post-screen detected cancers. So that is currently what we're doing in Ontario. We were here a few months ago talking about supplemental screening and the risks and benefits and where that's fitting in with the screening program. Supplemental screening with ultrasound, with ABIS, with MRI is currently not part of the screening program. We do have some recommendations because OTAC looked at it. There's no funding, like in terms of like increasing capacity for supplemental screening right now, because that business, like we haven't worked with the ministry to do that yet. I'm happy to come back in the future. It's a whole topic on itself, looking at all the different supplemental screening tests and the risks and benefits. So I'm happy to come back at a future time to like talk about it. But any questions about supplemental screening with ultrasound, right now it's considered outside the OBSP.
Okay, thanks for clarifying where things are at the moment, Samantha. Another question just regarding OBSP and, oh, sorry, Jonathan, were you going to jump in there? Oh, okay. Regarding the OBSP program, somebody had asked, do they inform patients if they have breast cancer, or would they only get, well, what sort of letters would they get in the case of an abnormal screen?
Okay, no, that's a great question. So right now, if someone has a normal screen, they get a normal results letter, which discloses the normal result, actually discloses their breast density. So it will say what breast density level they are, and it will also say their recall interval. The abnormal results, which usually on that first stage of screening, we're not diagnosing breast cancer because we do not have, it's just an imaging finding. Usually that the site's liaison with the primary care, or their, for patients who don't have primary care, the PCP designate at the site, and the sites usually have a process to recall the person back and do further testing on the participant.
Excellent, thanks very much regarding answering that question. There was a few comments actually in the chat just around language, the use of false positives, and whether, you know, maybe it's better to describe it as benign findings that need investigation. I just wondered if you had any comments in terms of how to have that discussion with the 40 to 49 group in particular, where they're going to be experiencing more of those false positives.
Anytime someone comes in for the first time screen, like we don't have a comparison. So anything, and like for me as a radiologist, I'm looking for symmetry. So anything that's a bit asymmetrical, but it could be normal, like we're more likely to like do further testing on it. So that first time screen does have more, we call recalls or false positives. I'm hesitant to totally dismiss. That is the epidemiologic term when you have an abnormality on a test. It's a false positive. That's what epidemiologists do, and that's like how they calculate. That's sort of the accepted term for having an abnormality on a test and requesting someone has more testing. And I think it's maybe not accurate to say this is all. It's likely not to be cancer, but I wouldn't want to totally dismiss it and say it's benign findings. You're just going for extra testing, because at that point we don't really know. You know, that's why we're looking for cancer. So we are trying. It is important that the person comes back for that extra testing to see if it's just to see what it is. 9 out of 10 people who come back are not going to have cancer, but we don't know out of that 9 out of 10 who's going to have cancer or not. But I think as part of the informed decision-making discussions, I think sort of discussing the screening process with future participants is very important for them to understand that we do, because it's an imaging test, unlike colonoscopy or cervical cancer screening where they're doing tissue pathology, we do have a higher of this false positive rate. We do have like more people coming back for extra testing. And that can really alleviate a lot of the anxiety around that extra testing.
Another thing I just want to add is that just something to keep in mind is that the risks associated with undergoing a biopsy for breast compared to the risks associated with undergoing a biopsy for, let's say, a prostate are different, right? And maybe that just as healthcare providers, when we think about the benefits and risks, that certainly is something that you want to sort of keep in the back of your minds, because, you know, with prostate biopsies, there's a risk of hospitalization and bleeding, and therefore, if it is a false positive, like, you know, that balance between benefits and risks is sort of shifted in one direction. Whereas for a breast biopsy, there isn't that same type of risk, and certainly that is something that can be factored into how you think about benefits and risks. Thanks.
Thanks, both of you. A question just around radiation. Is there a risk of radiation for mammography? And why not have yearly mammograms for everyone, or even at least for those with density type C?
Okay, so that's a great question. There's actually, mammography is a very low radiation dose test. There's been there's really no negative effects known from using mammography for medical testing in appropriate fashion. It's equivalent to maybe like 4 to 6 weeks of like background radiation. So it's a very safe test, very low dose radiation profile. Like I said before, it has been looked at screening people in Canada, people with BI-RADS D, it has been shown to be beneficial to have that more intensive screening frequency. That like they do model out different screening, the Canadian Task Force does model out like different screening strategies, and the way we're screening every 2 years does have that like balance between like cancer detection versus false positive, bringing most people back every 2 years versus every year. And then we do have that cohort within the screening program that's like higher than average risk that comes back every year. So based on family history, the BI-RADS D density, if they've had high risk pathology lesions in the past.
Excellent. Thanks very much, Sam. And I think I might actually turn over to Jobin now. We'll just finish off the last of our slides before 9 o'clock, and then we'll come back because there are some additional questions.
Yeah, thanks so much. Antibiotic resistance is a significant public health crisis with 1.2 million deaths annually attributed to it. And we know that overuse and misuse of antibiotics are key drivers, particularly within primary care. And so having options like peer comparison audits and feedback on antibiotic prescribing is an effective way to change behavior and reduce unnecessary use. Dr. Kevin Schwartz will be reviewing the evidence on how this approach can improve patient care and explore how it can be incorporated in action plans on November 14th. So we want to see if people can sign up for that. We think it's going to be a really good session. As we go to the next slide, osteoporosis care gaps can be a major problem because we know osteoporosis fractures are significant, though overlooked. And so the team's going to be focusing on evidence-based strategies for fracture risk assessment, reassessment, interventions like nutrition, exercise, and pharmacologic treatment, really aiming for a shared decision-making approach with patients to prevent fractures. So that's on December 4th, and the QR code is there. Just a last point on the next slide. The two new next community of practices that'll be coming up, AI and technology, which we know are transforming family medicine, whether it's through virtual visits or AI-assisted charting or consults. A family physician, Dr. Cody Jackson, as well as Ariane Siegel, who's a general counsel and chief privacy officer at Ontario MD, are going to be discussing how to integrate these tools while also maintaining physician wellness and privacy as well. And then also for children with mental health, family physicians often have to step in because of referral delays. So family physicians, Dr. Lalani, Dr. Grieg, as well as their psychiatry colleague, Dr. Javed, will be providing practical approaches for managing depression, including assessment tools, treatment options, and referral pathways. With that, I'll hand it back to you, Eleanor.
Great, thanks very much. I just wanted to bring everyone's attention to one additional program that's being run called Peers for Joy in Work. I participated in this myself and would encourage others to consider it. And we have just a little short video about it so you can learn whether it's something you would like to participate in yourself as well. Oops, no audio, I think there, but you did see a familiar face, Ali Damji.
You're
So
experiencing. The benefits of this program is that there is an opportunity for you to work directly with a colleague that understands family medicine. They are experiencing similar challenges to what you're experiencing. And they also understand that it can often feel like we're stuck in a hole almost, and that we're not able to pull ourselves out of it. And what this program really is there's someone who's going to come with you and help guide you on that journey so you can pull yourself out of that hole, and also appreciate the fact that we're actually in an amazing discipline that has a lot of opportunity for joy, and it really helps when it's someone who gets it.
I would say it felt like almost working with a therapist who was a family doctor. I found the Peers for Joy program to provide a lot of validation of some of the struggles I was facing in family medicine, as well as having a colleague or peer who had gone through similar emotions, but then also made changes in their life to let me see what, if I took a different route, what things would look like.
okay, so just something to think about. Next slide, please. So just a reminder, this session is part of a whole series of sessions. So feel free to check out our previous ones, especially some people had questions around the RSV vaccine, which we covered a couple of times in July and September, I believe. So certainly look back over those. Next slide, please. And then just in response to people wanting to know when our next sessions were, we've decided to throw out all our dates here. So if you're looking to block your calendars, here are the dates. Our next session coming up in November 17th, and then following that December 6th. Next slide, please. Reminder that all our questions and answers are posted online, as well as the slides, and the show can be watched again should you so desire. Next slide, please. I think that's the end of our slides. So we can take those down, and we're just closing out before 9. There are a few more questions, so for those of you that would like to stick around, I will perhaps get all of our panelists back on screen so that I can throw a few more questions their way. Actually, I wanted to start with you, Allison. There was a question that you answered. You wrote the answer to, but I thought would be helpful to just to mention live, which was around the rapid tests that have expired. And there was a further question as to whether you can not trust false positives or you could not trust them either positively or negatively if the results come back. So just what to do with those expired tests and whether we can use them at all.
So, I think if a test has been expired for a month, you're probably reasonably okay. But we just don't know how long that tests hold up. And in general, rapid tests don't hold up forever. The FDA has still not extended the life of some of these tests beyond 18 months. Health Canada and the EMEA have given them generally 2 years. But 2 years and 9 months, the correct answer is you just can't tell. And you don't know whether it's false positive or false negative. And I don't think there's anybody out there testing them to know. So the answer is, I think anything that's been expired for more than a couple of months, you just need to, let it go. But you can access family physicians, my understanding, you can access them through the PPE portal, right? For the office and for high-risk patients. And you can also buy them. They're, I don't know, $25 or $30 for a pack of 5. So they're not impossibly expensive for most people if people want them. But I think, I frequently use things that are outdated of a variety of sorts, but COVID tests at 9 months, I don't think so.
Great. Yeah, thanks for clarifying that, Allison. And there was one other question that you had answered that I thought was also helpful for us to just mention live, which was around testing ourselves for COVID. When would you be recommending that, or what's your approach to to us being tested and going to work, if, just how to manage things for ourselves as primary care providers?
The general recommendation is that you don't need to test now. Any respiratory infection is, likely to be caused by a virus, and you're going to be infectious to other people, and you don't want to be passing it around, which means that for most of us, the chance that you're going to be able to identify, mostly what's circulating now is enterorhinovirus, not COVID. And even in peak season, there's a lot of stuff that we just don't have a diagnosis for. So, you can test for COVID. Your chances of having COVID at the moment are 10% or less. So there's an argument for saying it's not really valuable. And if you can, stay home for the first 3 days and wear a mask for the next couple of days, if you're around vulnerable people or in crowded indoor spaces, that's probably as good as it gets. On the other hand, we have rapid tests available, and there's absolutely nothing wrong with doing a rapid test as long as, I think the difference is that if I test positive for COVID, I'm probably going to be a little bit more careful than I might be if I test negative for COVID and think I just have enterorhinovirus. So to the extent that it might make me more careful, there may be some benefit in testing for COVID. And there's nothing wrong with wanting to know what you have, right? All of us kind of want to know what we have. And so if you want to buy COVID tests or use the COVID tests you have to identify whether you have COVID, it's okay with me. There's nothing wrong with it. But the principle is, staying home when you're sick. I think there's also if you're on the balancing of, there's some really important argument why I need to go into work versus not. And a positive COVID test is going to make you say, okay, I'm still higher risk to other people. I should not do that. That's maybe another reason for thinking about doing COVID test. Happy to have Dan weigh in on it.
Thanks.
Everything Allison said. And just, I put in the chat, but if you want to know what's circulating now, WHO has an Ontario respiratory virus tool that gives you percent positivity, hospitalization outbreaks for COVID, flu, RSV, enterorhino, adenovirus, like it's all there. So if you want to see what's circulating, just go to that tool and you can know.
Thanks, Dan. That's very helpful to know we have access to that. Just a follow-up question for Allison. Do you need a positive test currently in order to prescribe Paxlovid, or can you leave us a prescription at the pharmacy for a patient to fill if they test positive in the future?
So I think what you heard Dan say is that if you're using Ontario Supply and a limited use code, then you have to have a documented positive test. Otherwise, you have to have a positive test, but it can be verbally documented. And, I think in particular circumstances, if you or the patient are willing to say there's a positive test, you should be able to get a prescription filled that somebody is paying for.
Yeah, I'll just add, Allison, sorry. So if it's ODB coverage, you need that confirmation of positive. The prescription can still be there in advance with the pharmacy or with the patient. It just can only be filled and dispensed with the positive. If it's not ODB covered and you're just paying privately, there aren't actually rules about having to have a positive dispense. It's more about, pharmacist comfort given the existing rules for the ODB one. So if you're just prescribing to someone and they're paying out of pocket, they could pick it up.
Great.
I think pharmacists may, there's going to be this ongoing confusion that needs to be clarified. But I do think it is not unreasonable for, immunocompromised people who are traveling a lot and who are at risk of COVID to have Paxlovid with them. And if they're paying for it, to me, that's a completely reasonable thing. That's a very small subgroup of people, though.
Thank you, both of you, for clarifying that. A couple of questions for you, Dan, just around vaccine administration. So where can younger, like less than 4, less than 2-year-olds get their COVID vaccines was the first question.
Yeah, good question. So it's unfortunately there's not a lot of great access. So all health units have some clinics specifically devoted to kids under 5, basically, because there's not a lot of other places to get. Some pharmacists are comfortable administering to kids and they have the scope of practice to administer down to 6 months, but it obviously depends on the individual pharmacist, the setup in the pharmacy, if they have space to do it, et cetera, whether or not they can administer a kid that young. And so easy to say that probably most pharmacies are not doing 6-month-old. And of course, primary care providers can all administer COVID vaccines to kids that young if you want to and want to use COVAX. So it's variable by community. And I think if you have questions, I would always reach out to either local pharmacy and the local public health unit to see what's available.
Okay, and another group population in terms of COVID vaccines. How do we arrange for our housebound patients living at home to get COVID vaccines?
Yeah, and again, it is a little bit variable by community. So the OH at home program does have the ability to administer COVID vaccines, flu vaccines as well. I don't think RSV this year, but COVID and flu to housebound patients. But obviously, the accessibility to that is dependent on the region. Other regions have had other methods put in place, working with health units who are doing homebound, community paramedics, et cetera. So it depends a little bit. Again, I would start with OH at home if that's the question that you have for a homebound patient, especially if they're already receiving those services. Otherwise, you can contact local public health to see what else might be in place.
Thanks, Dan. One last question around the COVID vaccine. Kim was wondering, is there a reason that Shoppers Drug Mart is preferentially getting the COVID vaccine? She's been trying to get it for her high-risk husband, and their pharmacy was told they wouldn't be getting it until Shoppers Drug Mart has received all theirs. Not sure if this is the case or not, but any comments on that?
I hadn't heard that. So it just is how quickly the distributors get to various pharmacies. And it's different by every region, as you'd expect, based on location. So there isn't a preference for any particular pharmacy. It's just how fast they can deliver to whichever store. So it depends on where you are, where that store is located, and when that supply will come in.
Great, thanks very much. I think at this point, I'm going to turn over to Jonathan and Samantha with a few questions for you regarding the OBSP program. So one question is for category D breasts. Why are patients being screened with annual mammograms when the better diagnostic tool is tomosynthesis or MRIs?
Okay, that's a great question. Actually, part of I didn't get into this, but actually part of the expansion as of October 8th, the sites that do have tomosynthesis can offer it to their patients for screening. So that's a change in screening. We don't have enough evidence. Mostly the tomosynthesis is shown to lower the false positive rate. We suspect it probably improves the cancer detection rate. We actually don't have good quality evidence showing that yet. So we don't have the evidence to make to give specific recommendations on how the site should be using tomosynthesis in their practice. So the site, it's really going to be up to the site. No, it's not widely available in Ontario. There's a lot of logistical hurdles to getting a tomosynthesis unit in the community. So it's not widely available, but the sites that have it can choose to use it and how they think can best serve their patients. What was the other part of the question? Was the
MRI.
Oh, MRI. Yeah. So we really don't have we're right now, our breast MRI capacity is extremely low. We're having trouble even getting in the high-risk patients and the recommended screening intervals for breast MRI. We really, in order to offer it on a population level, we really do have to we don't have the capacity right now to offer it on a population level. And we're really going to be continuing to monitor, there's clinical trials, they're looking at emerging technologies and difference, but I really would rather come back and talk about all the supplemental screening modalities, but really mammography is the preferred test in the average risk population for screening. And we have shown that it is beneficial to screen annually versus biannually, especially in that VIRADS D population.
Thanks, Samantha. Just in terms of that, again, that high density group, should we routinely, and I'm sorry, this is getting on the supplemental event, but should breast ultrasound be also ordered for that group or not necessarily?
It's okay. So breast ultrasound has a very high false positive rate, probably especially in the way we practice in Ontario, where we have a lot of small sites doing screening. And it has a lot of those results, a lot of those false positive results actually result in biopsy, which isn't true for mammography. Most of the mammography in terms of radiology screening tests has like an acceptable false positive rate, and very few end up in biopsy. But ultrasound has a very high false positive rate, and a lot of them will end up in biopsy. So, and the incremental cancer detection rate is relatively low compared to other modalities. So it's really like would be like a risk benefit discussion. It's very time consuming. A lot of the sites really don't have even the capacity to really offer this on a population level at this time, because we really haven't built that capacity in the system.
Great, thanks. I think it's actually really helpful for you to just how you described some of the real challenges with using it on a regular basis. So thanks for explaining that around the use of ultrasound. I'm actually going to turn back to Allison and Dan for one last question, and then we'll close out the session, just because it was a question with quite a few upvotes. So in terms of the general population, if we can't test for COVID now, how can we diagnose potential long COVID-like illness if patients aren't able to prove that they had COVID in the first place?
You want to go, Allison, or I can start? I guess the first thing is, I mean, if they have symptoms consistent with COVID and then symptoms consistent with, you know, post-COVID condition following something like that, even if they don't have an official positive test, you can still treat accordingly. The other thing is that, you know, post-COVID condition in terms of treatment, for a lot of those prolonged symptoms, the treatment is not really dependent on being post-COVID versus another post-viral, post-infectious condition, right? There's such broad overlap between those generic symptoms, whether it's, you know, fatigue, et cetera, that the treatments aren't specific to having had COVID, they're specific to the symptoms. So regardless, again, I would still be treating those symptoms following that protocol. And if you say, well, they had an infection in September and there was a lot of COVID or a bunch of COVID at the time, and now they're post-COVID-like picture, I would just treat them that way. And having that positive test doesn't really change management in that situation. I don't know, Allison, if you would suggest anything else.
Yeah, no, exactly what Dan said. I mean, I think that there's been so much COVID and so much post-COVID condition that we have forgotten a little bit that there are lots of people who get post-viral conditions, and as with post-COVID condition, really hard to diagnose, difficult to manage, very difficult to live with. But it can happen after many other viruses and in other circumstances, sometimes in which we're not even sure what the trigger is. So I think the answer is, as Dan says, that you're treating the complex of symptoms. And you know, we just got to keep hoping that the incentive of having so many people with post-COVID condition will help with making the research breakthroughs that'll tell us what triggers this and how we can manage it more effectively.
Thank you both, Allison and Dan, for speaking to that question. And at this point, I wanted to just thank all of our 4 panelists. I think we've had a lively discussion. Really appreciate your practical and approach and for keeping us up to date in areas from breast cancer to infectious disease. And I would remind participants that there were a lot of questions that were answered directly just through writing, and those curated question and answers are posted online. So you can always go back and have a look at them if there was the question that you didn't see answered live that you wanted to get the answer to. I hope everybody has a wonderful weekend, and thank you again, and look forward to seeing you all in November. Thanks again. Take care.